So this is the first of two videos looking at airway assessment and management. This video will focus primarily on the assessment of an airway and then the use of simple adjuncts to manage airway problems, before the second video will go on to talk more about the use of advanced adjuncts and intubation and surgical airway. In any situation where you think about managing an airway, it's important to try and determine what could be causing the problems. So thinking about the environment is a good starting point. Thinking about, are you in a restaurant that's maybe they've just had nuts for the first time? Is there vomit lying around the patient? Or are they involved in a car accident? And depending on the different mechanism, that might give you a different cause of airway problem. Simultaneously, any patient with a reduced GCS can result in loss of airway control by themselves, generally considered to be below a GCS of 8, that they would lose control of their own airway and they may need intervention to support this. So taking this into account when you're assessing any patient is really important. Assessing an airway can be as simple as look, listen, feel. Splitting it up into 3 simple areas is the easiest way to break down how you're assessing a patient, and the whole assessment can be done in just 30 seconds. So you're looking, first of all, can you see obvious chest rise, therefore their airway is patent? Can you see that there's nothing obviously obstructing their airway? Is there vomit in their mouth? Is there saliva? Is there blood lying around the patient, or is there evidence of significant facial trauma and bruising around the mouth? Moving on from this, after you've looked, you want to listen. So talk to your patient. If they can talk back to you clearly, they clearly have a patent airway, they're able to maintain good air entry into their lungs and pass that out in words. Next, you want to think about airway noises. Is there stridor or additional noises that might indicate airway obstruction? And in the worst situation, is there evidence of no noise at all? And that could indicate complete airway obstruction, or they're not breathing at all in the first place. All of which would warrant quick review and quick assessment in order to instigate management strategies. The first thing you do to manage any airway is triple maneuver. So head tilt and chin lift to assess to see if this makes a difference to the airway noise. Are they suddenly gone from gurgling or snoring to suddenly much more clear air entry? And if those two don't work, you'd move on to the third of our triple maneuver, which is a jaw thrust. In order to do this, you need to get good connection with your fingers underneath the mandibles and pull directly upwards. Don't pull forwards or in other directions. It's a direct vertical lift. Once you've successfully opened the airway, you now need to assess to make sure you can still get good oxygenation. Use a simple face mask or trauma mask, or you can bag valve mask them, either with a 2-person or a 1-person technique to ensure good air entry into the lungs. If there's an obvious obstruction in the mouth, you might think of a single finger sweep to move that out of the way, or the use of McGill's forceps to carefully remove the object. Use only under visual guidance, so don't just sweep blindly with your McGills, and make sure to pick it out and remove it. If you're not sure or you can't move it, just move on. They can probably still get air past the obstruction. The use of suction can also be really useful if it's a liquidy or fluid, so blood or saliva, to remove that, and you can use a yanker sucker to remove that. Next of all, you'd consider the use of an NPA or nasopharyngeal airway in order to gain better oxygenation to the patient and management of their airway. These are well tolerated in patients who have normal GCS. So to size these, you'd want to just use your judgment. There's no formal sizing method. You might have heard of things like using your pinky or finger size of the patient, but actually the best way is just to get your NPAs out and work out which one fits in best. In terms of putting these in place, you want to pass them with a little bit of lubricant on the end along the base of the nasal cavity, not pointing upwards towards the brain, but horizontally along the back of the nose. The only significant contraindication to using NPA is a base of skull fracture, which might be indicated by bruising behind their ears or CSF or blood passing through their nose or ears. And if you saw this, then you would at least avoid using an NPA if other airways were still possible. If an NPA fails or the patient has a significantly reduced GCS, you might consider using an oropharyngeal or a Goodell airway. These come in multiple sizes and they're plastic and more solid than an NPA and go in through the mouth. They can be sized from the vertical height between the incisors and the angle of the mandible. Once you've sized them, insert them upside down with the curve pointing upwards, and then twist as you insert it in. so that it passes down to the back of the airway. In order to tolerate an oropharyngeal, you need to be deeply unconscious. Generally, you'd expect this in patients with GCS below 7 or 8, and when someone begins to tolerate an oropharyngeal, you should remove it quickly to avoid them vomiting and gagging onto it. In some situations, it might be relevant that you have two nasopharyngeals and an oropharyngeal in the same patient, and that's absolutely fine. When you're moving between the ladder, you don't necessarily need to remove the last adjunct in order to move on to the next adjunct. If all of these options have failed and your simple adjuncts are no longer working, that's when you might move on to a supraglottic airway, more definitive airway like intubation, or in the worst situations, you might require a surgical airway. These will be talked about in the second video.